My name is Ogilvie. I'm an orthopedic surgeon, and I work with sarcoma patients of all ages, bone and soft tissue sarcoma. And I've been working here in Minnesota for 13 years. And did some of my training here and in San Francisco and in Canada, and did some work in doing the same type of thing in Philadelphia before I came back here. I'm from Minnesota. But that's me, and I really enjoy working with these patients because it's a variety of ages and different parts of the body, and uses my skills as an orthopedic surgeon to work with the bones, and then also my interest in anatomy to work in the different parts of the body. So it's an exciting thing to do, and it's a type of cancer. It's a type of tumor that really still needs a surgeon. Some of our tumors are curable with medical treatments, but surgeons are still needed for the bone and soft tissue tumors. We'll start with soft tissue sarcomas. Soft tissue is a very loaded term for us, and it means generally the connective tissues, what the orthopedic surgeons work with. And the sarcomas of soft tissues might be fat and muscle, even some of the nerves, and the smooth muscle and the blood vessels. So we get sarcomas that can occur in all different parts of the body, but many of them occur in the extremities and pelvis, and so they kind of fall under the areas that the orthopedic surgeons would treat. And for the most part, we don't know what causes soft tissue sarcomas. They're fairly random. We do know that high doses of radiation can cause soft tissue sarcomas, and there's some other conditions that they're associated with, but for the great majority of people, we never know what actually causes them. So the soft tissue sarcomas usually come up as a lump or a fullness, and many times they don't hurt. These are cancerous tumors that often don't hurt until they're quite large, and so people can think that they are something else, such as an injury, or they don't know what they are, but they don't hurt, so they can't be all that bad, is what people think. And so sometimes we don't see them until they're pretty good sized, but they can be very superficial, right underneath the skin, or they can be deep down in the muscles or even along the bones. So soft tissue sarcomas we see most often in adults and older people, although every now and then we'll see them in kids as well. And they are serious conditions because they can spread to the lungs and to other parts of the body occasionally. We treat them usually with radiation, sometimes chemotherapy, and almost always have to do surgery at some point to get them out. And so that's my job, is the surgery part of it. And also I get involved in the beginning because I often will do the biopsies to find out what they are. Sometimes we'll do those in clinic with a needle biopsy, and most teenagers and adults, we can do that. We numb up the skin a little bit, and that helps us get things going quicker to find the diagnosis so we can get started with the treatment. For the real little kids, that's hard to do in clinics, so we often will do the biopsies in the operating room. Bonesarcomas are fairly different. The bonesarcomas we'll see much more in the younger people, and occasionally in adults. We'll often see it in kids that are growing rapidly, and we'll see some of the sarcomas, such as the osteosarcoma, in the areas of the bone that grow the most, so around the knee and the shoulder. And those are rarely biopsied in clinic, but we usually have to do that in the operating room, just because the bone is more sensitive and difficult to numb up in the clinical setting. So I'll see those people. Typically they come to their doctor because they are painful, so different than the soft tissue sarcomas. These are almost always painful, and people will have a swollen area, and they'll get an x-ray that'll look pretty abnormal, and then they'll send them in to see us, and we'll get that initial biopsy. And then very quickly we call the medical oncologist for the osteosarcomas and get them medical treatment. So for some of the sarcomas, such as osteosarcoma and Ewing sarcoma, we give chemotherapy up front, and that's really effective. Not so much for changing the sarcoma where it starts in the bone, although it usually does kill it a fair amount, but the medical treatment is really helpful for the small amounts of sarcoma that spread to the lungs. In osteosarcoma, 80% of people spread before we even meet them. And so it's really important to take care of that, and the chemotherapy is what does that. So, so I meet them, I do the biopsy, we get them off to their medical treatment, and then they come back to have their tumor removed. And in most cases, we need to rebuild the bone, sometimes with bone from our bone bank, often with metal implants. There are other sarcomas that don't get chemotherapy. The cartilage cancers, the chondrosarcoma, which is more of an adult one, we would just get those taken out right away. And they're difficult because they're not sensitive to chemotherapy or radiation, so I don't have any backup with those. So we need to get them all out, and then we rebuild the bone. So there's a variety of different kinds, and we rely heavily on our pathologists to help sort that out so that we can get them into the right initial treatment. But as I said, eventually they all need to come out and return back to me to get the tumor removed and the bone rebuilt. Similar to the soft tissue sarcomas, we usually don't know what causes the bone sarcomas. We know radiation is a cause. There are some genetic conditions, rare ones, and there are some benign bone tumors that are known to have a small incidence of developing into bone sarcomas. And those mostly osteosarcomas, but those are all pretty rare, but they're certainly things that we think about on a regular basis. Many times people have been to 4 or 5 doctors by the time they see me. So they'll go to their primary doctor or to the emergency room, and hopefully someone will do an examination where they're saying, oh yeah, there's a lump there, and they might get an x-ray. And sometimes for the bone sarcomas, it's pretty clear on the x-ray what's going on, and the radiologist will be the first one to raise that possibility. For the soft tissue sarcomas, it's more difficult. Sometimes they're misdiagnosed as an injury, pulled muscle, and what we hope is when that's the case that they'll get some pretty quick follow-up with their doctors who made that presumptive diagnosis, so that they can decide if that's really, are they getting better or not, and if they're not, then we hope that they'll do some more imaging. So usually it's someone ordering some imaging for the soft tissue sarcomas and the bone sarcomas. We like to get MRIs eventually, and that helps us understand, number one, if there's a growth, and number two, its relationship to the other structures, and helps me plan the biopsy and any of the procedures. Unfortunately, the imaging studies for soft tissue sarcomas don't usually tell us what they are, and so you eventually, to get that diagnosis, you have to have a biopsy. And we will do that for the bone sarcomas as well, but it's more often on the bone sarcomas that we know what they are before we have a pretty good idea what they are before we do the biopsy, and we're doing that just to confirm things. So most of the time people come in with that lump or bump, and they'll need some additional tests such as x-rays or an MRI, and then they will be sent to someone who can do a biopsy. And usually that's the surgeons like myself who are accustomed to taking it out. We prefer that because sometimes the incision can be contaminated by tumor at the time of the biopsy and will have to be removed at the time that the tumor is removed. And it's best to put that incision in a place that's easy to remove. And if you're not thinking and doing the removals on a regular basis, you may not have the best idea of where to put those biopsy incisions. So needle biopsies are great. If they're a incisional surgical biopsy, we hope that the treating surgeons will be doing those. They seem to have the best outcomes according to several studies that have been done. So that's usually how people get discovered and diagnosed. Yeah, so we have a lot of members on the team. Most often, people will be referred in by a community doctor. Sometimes they come from our medical oncologists who see them first. So the team for many of these tumors, especially the soft tissue sarcomas, are the surgeons, the medical oncologists that do chemotherapy, and the radiation oncologists that do the radiation, of course. And so those are the three main treatments, and there's some tumors where we use all three of them. We have a working group that reviews all our surgeries and biopsies, and that includes all those parties, so we all get to weigh in on all the tumors, and some people say, oh, I don't have anything, or you need to take care of this, not me, or sometimes people say, oh, actually this will be a good one for us to do. So that keeps us all up to speed without having to guess whether someone would do it. We have these meetings every week. So we have those three pillars of the treatment, and one, two, or three of them may be used in any given case. Within our surgical group, we have a great PA that's very good at wound issues and does a lot of follow-up and is very good at helping us in the operating room. We have resident trainees that are part of the inpatient care. They're very good at taking care of inpatients, and they also help with the surgical things and help in the clinic. I have a nurse that kind of has her finger on the pulse of all the patients and their progress, and kind of knows who's going where. If I don't know what's going on with the patient, I ask her, and if she doesn't know, she knows where to find out very quickly. And so she often does a communication with the patients about scheduling things and about what's coming up next. And the PA and the nurse often call people, but with results, and I do that often as well, and tell people how things are going or what's next. So we have all those people. We have 3 surgeons that do sarcoma work at our institution, and we have a number of administrative people that help with your leave paperwork, your family leave paperwork, or other things like that, gathering films and MRIs from your outside hospitals and what have you. So we have a lot of behind-the-scenes people that the patients really never meet that are really essential for making things work. But they, you get to meet a lot of new people when you come in. So. Well, I try to be very optimistic and enthusiastic about taking care of what they have. You know, our expectation is with every patient that, gosh, we'll be able to take this out, and we expect them to do well. And you know, we know by the numbers that some people have problems, some people have wound problems, some people have, you know, as I mentioned, for osteosarcoma, they have tumors that wind up in their lungs. But regardless, we give the patient something that they can do and a plan that they can start with, and we help them through the plan. So we really you know, enjoy treating these tumors because we feel like we're doing something that's actually helpful, that's going to lead to a cure for most of these patients. And so that's kind of the idea that I expressed going in, that I'm you know, I have something that'll actually help them, and we want to get that going, and here's what they can do, and let's get going, and we'll tackle this together. So you know, we want to acknowledge it's a lot sometimes to, well, it's a lot anytime you're told you have cancer, but it's a lot sometimes to juggle all the comings and goings, and so we provide some support for the logistics and keeping track of everything. And we also want to acknowledge that with the patients, and some people feel very overwhelmed, and you know, I tell them that's pretty normal to feel that way, but we try to focus on just the one thing that needs to happen next for them, and that, I think, helps them get started with it. It's very interesting to see people at the beginning feel very overwhelmed, and then, you know, by the end, they're just about ready to join our team because they're so experienced and knowledgeable about all the things that go on. It's quite a transformation. So I found that people who come with a list of questions, or better yet, come with somebody else that has a list of questions, that's really helpful, that they're able to write down that information and they feel like, oh, we've got, you know, all my neighbors and cousins and grandma's questions answered, and everything that I could think of. So I think the support system is really key. And I think it helps people to get through the ups and downs of that. I've seen that certainly with family and neighbors and friends. Whenever people have somebody with them, I think that they are more relaxed and they are, confident that they are going to get what they need. Right, so remission is the idea that as far as you know, you don't have any tumor and we're just kind of keeping an eye on things. And so after you have any treatment before surgery and then you have your surgery to get the tumor out, we watch people and we restage people, and that means that we repeat. Often it's imaging of the site where the tumor was. Often is an MRI, sometimes an X-ray, sometimes both. And then we do usually another scan, at least of the lungs and sometimes of more areas. I did clinic today. We had a lot of people where I was looking at the MRI of their leg and the CAT scan of their lungs, and we're looking for regrowth of the tumor. We're looking for spread to the lungs. And so when you're in remission, that means we don't think you have any tumor, but we watch people for a long time. And when I came, we just thought 5 years is probably it. And for many of the tumors, we realized that we have to watch them longer because there are occasionally people who show up with a recurrence of their tumor after 5 years. So for many of these tumors, we will watch people to 10 years, and we even have a long-term follow-up clinic that'll watch people indefinitely here at our institution. And so we hope people stay in remission forever. It's we don't trust the cancer, so it's hard to say people are cured. But after being in remission for a couple of years, your chance of having a recurrence or a repeat tumor is really low. And after you get out in that 5 or 10 year range, it's quite small. And so in the back of our mind, we think and hope that, but we tend to use the term remission. In the soft tissue sarcomas that we've done a good job of getting it all out, and they've had some radiation before or after surgery, it's not common, and we think it happens less than 5% of the time. It is, however, common for us to be very close to the tumor because we're trying to save the bone or save the vessels or save the nerve, and most of the time a millimeter is enough. What happens occasionally, though, is that these tumors will have what we call satellite nodules that might be very small, and they'll be outside around the main tumor, and we don't see those until they grow up big enough that we can see them. And the radiation is designed to help reduce the number of those, but that's still considered a recurrence when the tumor regrows in that same general area where it started. So that certainly can happen, and we want to examine the patients and image the patients, like I said, for many years to make sure that's not the case, and kind of give the patients an idea of what to look for as well. I mean, the notebook is a real gem that has all this patient information. I think the patient support has been an exceptional focus of this foundation that maybe other sarcomas foundations have been a little more research focused, but I really like the patient support. The notebook has been sent all over the country, and I've seen people with it, and it's a great comfort to people to say, oh, there's all this stuff on the internet, or I know nothing, and it's great to have something I can read and get a frame of reference for what what this is all about. And that's the patient support. It's extended to the multiple events of a great variety that appeal to lots of different people. And I think it really helps people to get out and see, oh, there's other people that had this condition. There's people that are younger than me and older than me, and other people who have kids, and also, quite honestly, be with other people who have lost loved ones. And I think that's a helpful function too of some of these meetings, that people can get together. And we've seen all the mental health challenges in the world with the pandemic and the less frequent connections we've had with other people are part of that. So I'm excited that can restart again, and we can have that opportunity to share. It's hard to quantify that, but it's clearly made a big help for some people. one of the main things I would say, it's a very treatable tumor. We have a very high success rate of being able to take care of it. And so that's why I'm optimistic about it. That's why I enjoy doing it, is because what we do, the majority of the time works really well. A surprising number of people come in and ask me if they're going to get to keep their arm or their leg, and they worry that the leg's at risk. And it's really unusual for us for someone to lose their leg, and usually we have these great options to rebuild it. When that happens, it's not something that happens suddenly. It's usually a process of us looking at various things. And so if there's difficult decisions to be made, they have time to think through them. But for the most part, I want people to come in and feel like, oh, this is something that can be taken care of. We have people that have seen lots of these things and have a lot of experience, and I just need to focus on what I need to do next, and they'll take care of all the details.